pleasure to be here. I was just saying to a colleague earlier, I was here as a child where I had a meal down the Nile there in what I think is now the Ritz-Carlton, and I never imagined I'd be standing here speaking to you all, so I'm really excited. I'd like to thank Professor Musa, who I actually met last year in Abu Dhabi when we first talked about me coming here, so I'm really excited to be here. I'm also really privileged to be talking after Dr. Falazad, who's given us a really helpful introduction to think about the broader context of the area that we work with. And finally, Professor Al-Bakri for chairing and supporting the chairing of this session, but also kindly driving me here this morning in Cairo's very exciting traffic. So, I am Bruce Clark. I'm here with my colleague Chloe Voles. We're both consultants at the Maudsley Hospital, which is based in London. And we both work in the UK's National Specialist Service for OCD and related disorders. I'm going to talk to you, I have 30 minutes today to talk to you about body dysmorphic disorder. I could talk all day about body dysmorphic disorder. It's a subject I feel very passionately about. So, what I want to do is just remind everybody what body dysmorphic disorder is, and then describe the clinical phenotype a little bit. I'm going to talk about the evidence-based treatments as we understand them. This is a very naive field. All of the research you might want to do is still to be done. It's still there for the taking. And I also want to present a trial that we were engaged with in our clinic. It was the first trial in the world, a randomized controlled trial using cognitive behavioral therapy for body dysmorphic disorder. And I wanted to share some of the results of that with you. So, just to remind people that body dysmorphic disorder has had a checkered history, actually. It's had various names, dysmorphophobia, monosymptomatic delusional disorder encapsulated this phenotype, and now DSM has appropriately moved body dysmorphic disorder into the group of obsessive compulsive and related disorders. And when ICD-11 comes out, we're still waiting for the date for that, the same thing is going to happen within ICD-11. There are clearly things which distinguish body dysmorphic disorder from other obsessive compulsive disorders, but it was aggregated into this group and moved away from the anxiety disorders due to all of the conditions within this chapter having compulsive behaviors associated with their presentation. So just to rehearse, body dysmorphic disorder is not a difficult diagnosis to make, in fact. If you look at the diagnostic criteria, a young person with BDD has a preoccupation with one or more perceived defects or flaws. They are perceived defects, not actual defects in appearance, and they are typically not observable or deemed to be very slight in somebody else's eyes. At some point over the course of the disorder, the person must engage in repetitive behaviors or mental acts in response to those appearance concerns. I'll talk about those a little bit later, but they include things such as mirror checking, comparing, skin picking, but I'll come back to the list of compulsive behaviors. And of course, like all disorders, in order for it to be a disorder, DSM mandates us to look for disorder criteria of impairment in social, occupational, or other areas of functioning. Of course, I'm a child and adolescent psychiatrist, and the area of function that we are very often thinking about is educational functioning. So, just before I talk about this slide, I really want to implore people to attend to body dysmorphic disorder, because I know when for the first 10 years I was a consultant psychiatrist in one of the clinics at the Maudsley Hospital, I don't think we ever gave much thought to body dysmorphic disorder. I was based in one of the Maudsley Hospital's community clinics, and every single day we'd have a team of people who were responsible for going to the accident and emergency to see young people who'd taken overdoses. And I'll talk later about how common suicide attempts and self-harming is within body dysmorphic disorder. And I have to say, rather shamefully, before I came to the team that I work in now, I don't recall ever having conversations with people who'd assessed folks in accident and emergency whether body dysmorphic disorder could be one of those issues. And I want to emphasize that because the truth is, when you meet patients with body dysmorphic disorder, the diagnosis is not difficult to make, but what is almost always the norm, thank you, is that, what is almost always the norm is that people feel tremendous shame regarding their symptomatology. And that's really important to remember. You've got to give the patients permission to talk about their symptoms. When you do so, and you talk about the areas of perceived defect, the typical BDD patient will have concerns about multiple areas of their body. Roughly, in all of the studies that have been undertaken, both in child and adult, 50% of the concerns will be focused on the face. That has been replicated across different communities. There was some good data came out of Iran recently looking at BDD in that context, and face-related preoccupations were still taking about half of the concern. Then the rest of the body fills up the rest of the pie chart, and different studies show often number 2 is genitalia within the areas of concern for young people, and so forth. Right, I mentioned earlier, I'll just move this, it's sort of in my eyesight. I mentioned earlier that repetitive behaviours are a mandatory requirement in order to make the diagnosis. And so very typically these young people are folks who, because of their concern, are spending many hours a day looking in mirrors, checking, or some of them avoid mirrors. They get quite distressed and concerned reflective surfaces in bathrooms, toilet roll holders. Someone told me the other day that they got very distressed and will get stuck in the bathroom because they caught their image within the chrome plating on the side of a toilet roll holder. They often compare themselves to old photographs. Young people are engaged with technologies, and we frequently meet people who are taking hundreds or thousands of selfies a day. They often put themselves at risk. They're placing these images out onto the internet and inviting commentary about their appearance. They remain convinced about the defects despite what people are saying about them. Grooming, plucking, picking, straightening, burning, taping, pricking, all of this comes into the sorts of behaviours that we see. And very typically we meet people who spend hours on end looking at the internet, researching different cosmetic procedures as well as different cosmetic surgeries. In adult populations, a third to 30 to 40% of adult patients with body dysmorphic disorder have actually had cosmetic surgeries. We meet people who've undertaken their own cosmetic procedures. There are well-documented case series of people who've tried their own rhinoplasties. A young person came through our hospital's services who'd removed her own breasts, buying surgical instruments on the internet and removing one breast and then removing another breast the following night. So the risks associated with this disorder are quite extreme if in some circumstances. So let me say something about the epidemiology, because as I say, if you just sit in your clinics, people will not tell you about this disorder unless you ask. But actually, if you do epidemiological surveys, they generally show roughly 2% or just short of 2% of the adult population have BDD. Now, in child and adolescent psychiatry, similar studies have been done, and again, it's about 1 to 1.8, so just shy of 2% of the population of adolescents will have body dysmorphic disorder. The prevalence, however, goes up significantly depending upon the clinical context. So if you do studies which have been done, Kathy Phillips at Brown looked in inpatient units where 5% of inpatients on psychiatric units met the diagnostic criteria for body dysmorphic disorder, and up it goes. Dermatology outpatient settings are very, very, it's very, very prevalent in that context. Up to 10% of patients in outpatient dermatology settings. In the milder end of the spectrum, there are more females than males because the disorder gets more severe. The sex incidence is roughly equal in specialist clinics. That's certainly what we find in our own clinic in London. What we do note is that it's almost never picked up in routine psychiatric screening. Adolescent onset is described as being the norm, with 80% of adults saying that their BDD started within adolescence. It's associated with high levels of distress. Now, I was given this slide by my colleague, Professor Veal, who runs the adult OCD and BDD service at the Maudsley Hospital. And this is a slide he put together following a patient's description of their sense of their own appearance and BDD. And it illustrates how preoccupying and also delusional a person's beliefs can be. 50% of patients with body dysmorphic disorder have delusional intensity beliefs about their disorder. And that's an important thing to remember. We meet many patients who are referred to us who have been treated as though they are psychotic. And as I mentioned earlier, BDD has had a checkered history and has moved around our diagnostic manuals. But the one thing that's been proven time and time again is that this disorder does not respond like a psychotic disorder. It is not responsive to antipsychotic medication. The earliest trial looking at monosymptomatic delusional disorder with body image concerns treated with Pimozide and showed no effect. That is still the case. The other thing that I think is really helpful about this slide from a patient's description, you can see, I hope, that the nose that is just completely taken over this person's sense of identity is in a spotlight, and the people around them are looking at them. And that is very often how people with BDD describe their sense of self, that everyone is looking at them. So, how do you screen for BDD? Well, it's actually very easy to start the conversation. This is a question I've stolen from Kathy Phillips' book, The Broken Mirror, and it's as simple as saying to people, some people are very bothered by the way they look. Is this a problem for you? So in a standard psychiatric screening, that can take you, 4 seconds to screen. If the answer is no, you can leave it behind, but then of course you can follow up with supplementary questions. It's important to emphasize that in screening for body dysmorphic disorder, you must also hold in mind eating disorders, and if the young person, or indeed adult, feels that all of the issues with their body would be explained and helped by weight loss, that is a diagnosis of anorexia nervosa. So you need to differentiate eating disorder and body dysmorphic disorder, and the two can coexist. And we work very closely alongside our colleagues in the National Eating Disorders Service in London, and we often shuttle patients between the two services. Now, this is an image drawn by a young adult who, actually this was an image where they were asked to draw themselves like a mirror image. So this isn't how they perceive themselves, this is how they think they look. And again, I think this very ably illustrates how delusional the thoughts about self-image can be. It's important to keep in mind, and this image helps us do that the sense of distress that comes with this is profound. So Chloe and I know very well when we're working with body dysmorphic disorder, just actually when you see these patients, how terrible they feel about their appearance. This image was drawn by a young man who was drawing how he felt about himself rather than what he looked like. And it's quite interesting that there's a mirror image of this slide where he was treated and felt much better at the end, and he's drawn a much more positive image, which I didn't bring along today to show you. So I've alluded to body dysmorphic disorder being a common disorder. It often coexists and can be part of a differential diagnosis. So body dysmorphic symptoms can often occur within OCD, so there's overlap, but it can also exist as a distinct entity. Likewise, it's extremely common for people with BDD to avoid social settings, so it's important to think about mood, eating disorders, and then, as I say, psychosis. I added this into the side because it is best not thought of as a psychotic disorder, but indeed we often see patients who have been treated and thought of as having psychosis, and it's actually really helpful just to run through those symptom questionnaires. When I talk about medication, I just want to say something about the treatment of delusional and non-delusional body dysmorphic disorder. So I've already spoken about why it's underdiagnosed. Clinicians are unfamiliar with the disorder very commonly. Patients are secretive. And young people's symptoms are very often mistaken as normal developmental concerns. Now, clearly, adolescence is associated with a growth, important maturational crises, and people have understandable concerns about their appearance. But when you find patients with body dysmorphic disorder who are meeting impairment criteria, very typically coming through our clinic, these are young people who are spending many hours a day with compulsions or mental compulsions relating to body image. So it's always worth thinking about across every obsessive compulsive disorder and related conditions. If something is taking more than an hour a day of your time, you need to be taking that condition seriously and thinking and screening more effectively, and perhaps thinking about offering support. So why is this important? I hope I've already started to impart a sense of that. But the rates of mortality associated with body dysmorphic disorder are very high across all populations. Specialist clinics such as ours, the one at Karolinska Institute, UCLA, Providence, Rhode Island, all show extremely high levels of suicidal ideation in this group. So 80% of patients in the largest cohort of adults at the UCLA clinic, 44% of patients in Kathy Phillips' follow-up trial had attempted suicide. Our own clinic shows that half of the young people we see with BDD have suicidal ideation. As you progress into adulthood, BDD is associated with high levels of substance misuse, with almost 50% of patients reporting that they start to use alcohol and other substances to deal with the way they're feeling about themselves. Self-surgery, I've alluded to already. Cosmetic surgery is a risk, and these are patients who typically have multiple cosmetic procedures, but also debt and other risks associated with it. We had a young person come through our clinic who had spent £1,000 on her mother's credit card on various cosmetic procedures, including lots of fake eyelashes. I had no idea you could spend so much on fake eyelashes. So in children and young people, the kids that we see very often have major impacts on their academic performance, dropping out of school, refusing to go outdoors. I reviewed someone on my last working day last Friday who hasn't been outdoors all summer, across the summer holidays, socially withdrawing from peer networks. This sense, as I hope that the image I gave you of everyone looks at me, and often the BDD patients will have that sort of delusional flavour to the way that society views them. I can tell you're all looking at me. I can tell you think my appearance is bad. I can tell by your appearance, Sama, that you're laughing at me. These sorts of comments are extremely common within BDD, and of course for a young person developing, that has a profound impact. So, let me talk a little bit then about what we know about the limited evidence base for treatment. I'm going to talk first about medication, so we're done with that, and then I want to focus on the psychological therapies and the trial that we've been undertaking. So we know from repeated evidence that the core tenet of treatment for BDD are two things, the same as all of the other obsessive compulsive disorders. That is serotonin reuptake inhibitors and cognitive behavioral therapy adapted for body dysmorphic disorder. So this is a very elegant trial. I like it. This was Eric Hollander at NYU. And this was one of the first trials for BDD where he started to prove with this elegant crossover trial that serotonergic agents are what are required in order to treat BDD. So in effect, it was a short trial, 16 weeks, and what they did was they started patients on desipramine, which is a noradrenergic agent, and you'll see over time, this is a measure of BDD, and the severity didn't change at all. Whereas those who were on clomipramine, which has serotonergic activity, started to show some improvements. At the crossover point, these guys switched over to the desipramine and their condition started to deteriorate, and somewhat more convincingly, those who were on the noradrenergic agent, once they started clomipramine, started to show improvements. I like that trial. There's obviously flaws with that sort of methodology, but there have been multiple studies in different contexts that have now repeatedly shown and convincingly shown that SRI medications are a central and the principal medication we should be using for this patient population. The next important point, if you're thinking about how to approach treatment, is that the treatment response for BDD symptoms is much slower than it is for depressive symptomatology. Recent meta-analyses have told us, helpfully, that when we're treating child and adolescent populations with depression, that 50% of people who are depressed and on an SRI medication will show some improvements within 2 weeks, and 2/3 of them will show an improvement by 1 month. So that's much earlier than certainly I was always told during my training. The point with BDD is it's a slower response. A treatment trial is typically 3 months. And this is a slide from a study Kathy Phillips did, which I really like, because this is the placebo group at the top, and this is the group who were given high-dose fluoxetine. And there's an asterisk here at 8 weeks, and it's only at 8 weeks where the confidence interval between the treatment group and the control arm differentiate from each other. It's at 8 weeks where the statistical significance and the difference comes in. And I like that graph because it always reminds me to tell parents that we will see an improvement perhaps in your child's mood first, but the core differences we want to see in their appearance concerns will take longer, and we're in for the long haul. So I'm summarising a number of important studies to just give the clear message that SRI medications are efficacious. They have a moderate effect size. That's been proven with case series and randomised controlled trials. In expert clinics, and I hope by sharing information everyone's expertise increases. Like all of the OCD and related disorders, you need to use the maximum tolerated dose approach. It's higher doses that are typically required, and up to 62% of kids, if you take them up to higher doses, will show an improvement with medication alone. I very much appreciate that the core central component of treatment is talking therapy, but I'm also mindful that I work with colleagues who don't necessarily have the luxury of fully resourced services, and it's important to remember that medication can be an efficacious treatment on its own. There are many trials, as I've alluded to, trying virtually everything in the pharmacological textbook for BDD, and to summarize, the majority of medications other than SRIs do not work for this disorder. Now, this is the point I wanted to make about those with delusional intensity beliefs about their appearance. They're utterly unshakable, and those who do not have delusional intensity beliefs. The important takeaway message, Albertini and the group, again at NYU, treated these folks with antipsychotic medication. It was ineffective, but most importantly, treated them with high-dose SRI medications and showed an equal response. The key takeaway message is delusional intensity beliefs of body dysmorphic disorder are also treated with SRI medications. And I often work with colleagues who are considering referring to our team in London, and I remind them that it's important to keep going. It takes a long time, and you'll need to increase to the maximum tolerated dose. And very often, if you're patient and explain that to the patients, you'll see the effects that you want to see. Right, moving on to cognitive behavioural therapy, which is the central tenet we knew from of treatment. We knew from adult research. This is a forest plot from a meta-analysis of case series and randomized controlled trials that BDD can effectively be treated with cognitive behavioural therapy. So we knew that, but actually there were very, very few trials. And a colleague of Chloe and mine, Georgina Krebs, wrote this paper from our clinic looking at a case series that we treated of young people using cognitive behavioural therapy and showed that it was an efficacious treatment. So this led us to design the first randomized control trial of CBT for body dysmorphic disorder in the world. So what we did was take the extant literature from adult mental health and adapt it to a child population. So in effect, we modified the CBT protocol for young people. I won't run you through in detail the trial design because I don't have time to do that, but we randomized 30 patients and we actually had really good take-up. They were referred in from our local clinics, typically across southeast England, but we did have some other wider national patients. We actually had to exclude, this was a crossover design, so everyone went into treatment and a group went into a waiting list control that had active monitoring because of the risk of suicide. We had to exclude some of the most severe cases, however, due to the high levels of suicidality in the population. So, this is the briefest summary. At the time we were doing this treatment trial, the CBT treatment was 14 weekly sessions of CBT based on psychoeducation with a heavy emphasis on exposure and response prevention within the CBT. We adapt and have various other models looking at modules that we can add on, including things such as mirror retraining and attention training. But I shall proceed. So, this was the results. This came out in the American Academy Journal. This was the data at 2 months, and what we're showing here on the y-axis is the severity of BDD, and this is the control group. And at 2 months, we're demonstrating 95% confidence intervals, and you'll have to believe me that I can get my laser pointer between those confidence intervals. At 2 months, there was shown to be a positive, significant effect of CBT for BDD. We've also now published the 12-month follow-up data, and I'm very pleased to report, and we worried about this, I have to say, that every patient got treatment, they were all crossed over, and then they were all followed up for 1 year with no further treatment, and largely the gains were maintained. I don't have time to go into a lot of the ins and outs of it. 50% of patients responded to treatment. Of course, 50% did not. All of the work is there to be done in terms of how do you improve response rate, how do you use medication to improve response. This was a CBT-focused treatment trial. I see time's marching on. The trial and the treatment was seen as very acceptable to the patients. It was well received by both patients and their parents. The risks of the trial, the blinded time in the trial was 6 months, during which 2 of our patients out of the 30 attempted suicide and had to come out of the trial. But otherwise we had good take-up and people maintained their adherence to the trial and stayed into the 12-month follow-up. So this was the first randomized controlled trial. Sabine Wilhelm, who's a colleague from Harvard, has done an open-label trial showing similar effects. They have a slightly longer treatment protocol, and we've also lengthened our treatment protocol in light of what Sabina gained from her understanding of treatment. The effect sizes for treatment were large where there was a response. However, there's a good number of patients in all cohorts which just use CBT, where there are patients who do not respond to treatment. So there is still substantial room for improvement, and I cannot emphasize enough how there is still so much research to be undertaken. Just a little word in my concluding comments about risk. Of all of the patients who entered the trial, as I mentioned, 2 attempted suicide during the 6 months of the active treatment phase. 17% of those patients who were referred to us from our local clinics had attempted suicide within their life. 43% had histories of self-harm in their past history, and 10% of the people we screened for the trial were too high risk to go in because of suicidal behaviours. That takes me back to my commentary at the beginning of my talk about don't forget to think about BDD, where you're meeting patients who have self-harm, where you're meeting people who have social anxiety, depression, or substance misuse. Please, I implore you, screen for body dysmorphic disorder. Kathy Phillips summarizes this in her book, and this is not a statistic that people are proud of, that body dysmorphic disorder is said to have the highest standardized mortality ratio of any mental health disorder. There are other complex risk issues to consider, as I say, during the course of our treatment and our research trial. We have kids who upload their image. There are sites internationally where you can upload your image, and cosmetic surgeons provide commentary on your appearance and suggest surgical enhancements. This is clearly not a positive thing for these young people. We've seen people who've attempted their own surgical procedures, taping faces, stapling skin, very risky sexual behaviours within the treatment trial. Of our 30 patients, 3 had pregnancy scares. There's something about impulsivity, I think, if people are showing you attention. Financial issues, stealing money to buy cosmetic procedures. Drug and alcohol, I've already talked about, is a very significant risk within this population. This is just to thank the members of the research team and various people. We saw Eric Taylor earlier, who was part of our reference group. Chloe, my colleague here, is very much an active part of this treatment protocol. And the image there is to show where my colleague in Maudsley Health in Abu Dhabi, that's our clinic in Abu Dhabi, where I'm also proud to work. So I'd like to thank you for your attention.
Thank you, Professor.